I think most rheumatologists do follow the use of non-biologic and simple DMARDs, of which probably the gold standard is methotrexate. One thing that I think is being utilized more, which I think is a good thing, is the parenteral use of methotrexate, the sub-Q administration where you have a better idea of absorption and levels. And at that point, you know, the American College of Rheumatology guidelines really offer a wide choice for the physician as the next level. You know, so patients that have not, for whatever reason, have not responded to methotrexate, you can use a different disease-modifying agent, leflunomide. For those very mild cases, sometimes we do use hydroxychloroquine with steroids being used as a flare. But very quickly, we've decided in treat to target, if after 3 months the patient does not, I would like to say, get to the status of remission, it's important to change or add therapy. And so usually the next set is the biologics and now the non-biologic inhibitors, the JAK inhibitors. So that pretty much is sort of been the standard of treatment. And then following those patients, if in 3 to 4 months they have not improved and reached what we call a low disease activity state, you should change or add. And I think most rheumatologists are following that treat to target algorithm. I think probably one of the things that we've made note of over the last maybe 5 years or so are the comorbidities that go along with the autoimmune diseases. You know, whether it's rheumatoid arthritis, psoriasis, psoriatic arthritis, lupus, we now know that cardiovascular disease is a very important comorbidity, and having one of these diseases increases your risk of heart attack. So in addition to treating the joints or the skin or the kidneys, we've had to always be concerned, obviously, about the high blood pressure and the cholesterol, but we have to really be keenly aware of making sure that the other risk factors for cardiovascular disease you know, are not a part of what's going on with the patient, because what good is it to make all of their joints feel good if they have a stroke? So I think that's been, you know, probably something, one of the hurdles. I wouldn't call it a hurdle, but at least certainly another consideration. The idea of shared decision-making, I think, is a really good thing, but there are some obstacles to the shared decision-making, and probably one of the things that most prescribers bemoan is that you'll sit and spend all of this time and you talk about all of the different options that we have now for treating, for example, rheumatoid arthritis, and then you're up against a formulary wall where you can't use the medication that you think is best for the patient. So I think that probably is another important obstacle.